we reviewed in the last session the specifics in the basics for the course. What is it that we need to understand in terms of basics? And this second part is going to consist on the technicalities of that. So for the fundamentals of a flap, I'm going to start with that. And the fundamentals will be based on the design, incision, elevation, placement, and suturing. In the flap design, we have to have enough access, a wide base of what we're working on, no tension, and we have to avoid the vasculature and the nerves.
So it's very important that when you are doing your flap, you start thinking of what are you going to be doing, how much space do you need, where are you going to be pulling, because you want to avoid tearing your flap. So we're going to be talking about 3 different flap designs that are very important. The one and the most common one that we're going to be utilizing is the envelope flap. Okay? Usually we start with small flaps because we want to be minimally invasive. However, if you need to extend either with vertical incisions or extending another teeth, don't feel bad, because if you cannot see, you're not doing a good service to your patient. So the reason why we're doing flaps is to access, to be able to visualize the bone. We rarely do flapless surgeries because even if you know that there's bone, you want to be 100% sure that the bone quality is good, that your implant is fully surrounded by bone once you're doing your surgery. To increase access, we can do, as I mentioned, some vertical incisions, usually on the mesial because the vascularity is always going to come from the distal. Or you can do 2 vertical incisions, and that way you'll have better access. Now, just keep in mind that every time that you're doing a vertical incision, you're going to have to put that vertical incision back into place, and you're going to be creating scar tissue. So if you're working in the aesthetic zone, be very, very careful not to put any verticals in the anterior, because you're going to be creating a lot of damage in your aesthetics.
One of the most important things when we're looking at flap design is to increase the access, and that's the major reason how we're going to design our flap. Let's say we're working only in one single tooth environment. Most likely, we're going to be able to extend our envelope flap to the adjacent teeth in the mesial line angle or the distal line angle. However, if we're going to be working in a segment that involves a multi-unit placement or multi-unit surgery, in this case, as it shows on the screen, perhaps doing the procedure between the first molar and the first premolar, if that is the area that is going to be involved, then our flap naturally will be extended. 2 teeth most likely in the anterior segment and 1 tooth in the posterior segment.
Now, you can also do alterations in the flap design. For example, if for those of you that are going to be doing lateral sinus lifts, you could extend your flap, do a combination, and then put a vertical incision. By extending your flap to the mesial, you're going to avoid placing a vertical in the mesial. It's 1 less vertical to suture, and you're not going to leave scar tissue in the aesthetic zone of your patients. So just keep in mind, the vertical is a great resource, but it also has its consequences. It's always going to be healthier to extend your incision 1 or 2 teeth to the mesial or the distal when possible.
Let's look at incisions. We have 2 main incisions that we have to talk about. The first one is the horizontal incision. And in the horizontal incision, we have 3 variances. The first one is intrasulcular. The second one is soft marginal. And the third one is a mid-crestal incision. From there on, the second category belongs to the vertical incisions. So let's review the horizontal incisions first. In the left side of the screen, you see the intrasulcular incision. That means the red line indicates how the blade travels parallel to the long axis of the tooth from the sulcus of the tooth all the way down to dissect the fibers until you touch the bone. So you will be aiming at the intersection between the bone crest and the tooth. That will be the intrasulcular incision, and that is the most common one. The other incision, which is going to be the soft marginal incision, is the second one as we see in the screen in here. The soft marginal incision maintains the same inclination. Now we're looking at somewhere into the 45-degree angle between the tooth and the long axis of the tooth and the gingiva. What that means is that the red line indicates that we are going to remove a marginal segment of tissue that is above of the crest of the bone, and by doing that, in turn, we're going to be able to reposition the flap, and the flap, when we reposition that, will be thinner. This is a very common incision when we have plenty amount of keratinized tissue. We'll review that in a moment. That keratinized tissue is crucial because if we protect that keratinized tissue, and we have plenty of that, we will be able to thin the flap, and by thinning the flap, the adaptation will be in a more optimal stage.
And obviously, the mid-crestal incision is an incision that's going to go right in the middle of the crest. And what you have to really put in consideration here is look at the markings or the scar tissue created by previous surgeries or the extractions. Because there's going to be an avascular zone, and you want to be right at that middle of that avascular zone, because if you were to shift your incision towards the buccal or the facial and not capture that into that avascular zone and have that whole avascular zone in one side of your flap, you're going to have a big area of necrosis. So really take in consideration that. The other thing that you want to do is, if you're apically positioning the tissues in order to put your tissues around an implant abutment, for example, you want to capture some of that keratinized tissue on the facial and on the lingual. For example, when you're working on the mandible, where you have less amount of keratinized tissue, you really want to share that keratinized tissue 360 degrees around that implant.
So in the incision design, you will always consider the amount of keratinized tissue, and I'm going to be pounding on that. Now, some of you may forget a couple of the concepts that we are reviewing right now. That's why we're recording this seminar. But in addition to, we will be right side by side, so that way we be able to tell you and remind you as you're making your incisions on site of the specifics. Now, if during the process of this webinar you have some questions, please don't hesitate to give us a text, either Eduardo or myself, at 617-821-9885 is written down in the chat box, or my cell phone at 617-834-0648. So remember, the incisions will have then two purposes: give you the access, and by giving you the access, you have to consider the keratinized tissue and the vascularity.
Now, vertical incisions, as I mentioned, they're not my preference or not our preference. However, they're a great tool in many circumstances. Because of that, you really need to know what is a correct placement of a vertical incision and what is the incorrect placement of a vertical incision. So if you look on the left side of the screen where it says correct, those incisions are placed right at the line angle, or either on the mesial or the distal. Okay, and if you look on the right side of the screen where it says incorrect, those incisions are placed right in the middle of the papilla, or right on the facial of the tooth, or right on the lingual of the tooth. So remember, if you're going to be placing vertical incisions, they always go on the line angles of the teeth, never on the middle of the papilla, or never on the middle of the tooth.
So we will have two types of flap elevations. And most of us, in the practice, we will be considering the first one, which is the full thickness flap, which is called a mucoperiosteal flap. What this flap means that when you reflect your flap after the incision, the flap will be peeling off the bone in addition to the periosteum. So the periosteum, remember, is that very fine piece of tissue that is attached to the bone that contains a lot of progenitor cells and a lot of vascularity. So that means that when you do a full thickness flap reflection, your flap is elevated directly from the bone, and that periosteum comes attached through that flap reflection. It's typically in a blunt direction, and we will use a periosteal elevator. Again, right on site, we will practice that. The second type of flap elevation is going to be called a split thickness flap. And the split thickness flap is somewhat what you saw in the picture before for a submarginal incision. We split the tissue, so that way we only have the connective tissue in the end of the flap and the periosteum with the other remaining part of the connective tissue attached to the bone. Most of the time, we are not going to practice this when we do implant placement because we don't need to. Now, if we're going to do combined therapy with some type of connective tissue graft or some type of soft tissue procedure, then we will probably use this type of flap.
Now, suturing. Suturing is going to be as important as elevating your flap. Just as we mentioned on how your design of your flap needs to be done very carefully, how the elevation of the flap needs to be very carefully, and with a lot of thought process, your suturing is not different. So first of all, we're going to review different suture materials, and we're going to review also some techniques. Okay? What are we looking in a suture? Well, we're looking for a needle that is going to have a reverse cut. Okay? For most procedures, we're going to have a 3/8 of a circle. We're looking for a suture that's going to be durable. We want those sutures to hold the tissues for at least 14 days. Why 14 days? Because if you review all the literature on flap maturation, after 14 days is when those fibers of collagen are strong enough for us to be able to remove those sutures. And if you pull those flaps back, they're not going to come out. The diameter of the suture, okay? You can, for most of the procedures that we're going to be using, between a 4/0 to a 6/0, it's going to be a thickness that is going to be very easy for us to manipulate. And with all the movements on the mouth, it's going to be able to resist all the forces in there. Filaments. We want a monofilament. We don't want a lot of threads on our suture, like silk. Why? Because we don't want bacteria going in between those threads, going into our tissue and creating abscesses on our tissues. Tensile strength, as I mentioned before, we want that tension to stay there for about 14 days. So at least something that will maintain at least 50% of the strength for a time of 11 to 13 days. And of course, a suture that's easy to handle. Our suture of choice for most of the implant procedure is going to be a polyglycolic acid and polycarprolactam acid, which is a suture very similar to nylon, but the difference is that this suture is going to dissolve inside the patient's mouth if we leave it there for at least 6 weeks. So let's say, for example, you have a suture that's difficult to take out. Don't worry about it. Cut the ends of the suture, leave it underneath the tissue, and after 6 weeks, the body of your patient will make sure that that tissue is completely gone. Different types of suturing techniques that we're going to be using and we're going to be reviewing once we get all together in Mexico is going to be the single interrupted vertical mattress to approximate tissues. For example, if we're doing bone grafting procedures and we need to bring the tissues together, horizontal mattresses are going to help us for that. Horizontal X mattresses when we're going to be doing a lot of extractions, continuous sutures for those of you that are going to be doing overdentures, and other types of sutures. Now, it doesn't matter which type of suturing technique we're going to be using. The type of knot that we're going to be using is going to be a surgeon's knot. As I said, the single interrupted suture is going to help us approximate the tissues. Vertical mattress is going to help us apically position the tissues around our healing abutments, while the horizontal mattress is going to help us bring the tissues together on a coronally positioning manner. Horizontal mattress for sockets, continuous for long spans, for example, in those overdentures and others. Now, your surgeon's knot, you're going to do 2 turns to the same side, and then you're going to do 1 turn to the other. If you still feel that you need an extra turn, go ahead and do it. Don't feel bad about it, okay? Another very important thing is look how the first set of turns allow the sutures to stay flat. By keeping those sutures flat, you're going to be able to release both of your hands, and the tension of your knot is going to stay there, and your flaps are going to stay where you are, so you can go ahead and do your next turn. So when you're doing your turns and you're pulling, make sure that your sutures stay flat and they don't start to crumble altogether.
Some of the suture principles that we have to remember is going to be from movable tissue to the fixed tissue. That means that sometimes we feel that it's easier for us to engage and anchor a solid tissue, like part of that is attached to the bone, but it's actually not true. The one that moves in the flap, if we start our engagement on the suture on that movable part of the tissue, is very easy then to manipulate, and with the needle itself, bring it over directly to where we want to position it. So remember, the suture technique will always go from movable to fixed tissue.
Remember that your bias should be at least 3 millimeters or more from the flap margin. In my rules, 5 millimeters is ideal, because 3 millimeters is many times very difficult to measure. So always make sure that you take more tissue. Why? Because if you're very close to the edge of your flap, those flaps are going to start to necrose, and then you're going to have flaps that are going to start opening.
Now, that's obviously a deep bite. And deep bite is going to help you to avoid the tearing, as Dr. Markshammer mentioned, but also it's going to allow you to introduce the entire curvature of the needle inside of the flap that you're going to try to stabilize, and the curvature is going to dictate the exit of that. Don't worry if we have not shown you pictures of this particular aspect of suturing. You will have a hands-on training on that to make sure that you get proficient before you do it in your patient, and chairside you also want to have this training. Just these principles as for you to remember.
Always protect the tip of the needle. If you damage the tip of the needle, you may need to open another suture. It's more waste, something that you don't need. If you're careful with your needles, you'll be able to use, for most procedures, one package of suture throughout the procedure. If you start damaging the needle, then you're not going to be able to pierce the tissues without damaging them, and that will start creating more flap damage. And keep your ends at least at 3 millimeters, especially with this monofilaments. If you keep them a little bit longer, they'll bend a little bit more, and they'll create less discomfort to your patients.
Let's review the three-dimensional placement of implants. And in that three-dimensional placement of implants, we have to think about how to avoid risk. Placing an implant, is, as some of you have done, is not difficult. The difficult part is to keep everything in mind in how to avoid the risks. Because if we avoid the risks, we'll be able to have a successful outcome. But if we are not careful about those risks, we end up jeopardizing our procedures.
So we're going to be looking at 4 dimensions, and you'll understand why the 4th dimension in a few minutes. The first dimension that we're going to be talking about is the apical coronal dimension, okay? Whenever you're placing an implant, you've got to think that your implant's going to go 2 to 3 millimeters from the margin of your final restoration. Why 2 to 3 millimeters? Because that's going to allow a space in between the shoulder of your implant to the margin of your restoration, where you're going to be able to fit an abutment that's going to go underneath the tissues to create a nice emergence profile. If you were to sink more that implant, you will end up having a bigger remodeling around that implant for the establishment of the biologic width, more penetration of bacteria, and you will end up with an aesthetic problem. Now, most of these concepts came from the placement of implants in the aesthetic zone. However, we could apply these concepts to any part of the mouth. So you can see now the margin of that restoration compared to the margin of the neighboring tooth. Now, also be careful not to place those implants too high, because what you're seeing over there, it's a cover screw. It's not a healing abutment, okay? Sometimes with the fear of the position of the mandibular nerve, we might not put those implants in the right position, or if we don't have in our armamentarium the right implant that's short enough to be able to be placed in the right position, we might end up putting an implant that's longer and not put that implant all the way to its final position. This was actually a student, a dental student that had this implant placed in Florida, and the treatment for, to be able to restore this implant was the removal of an implant and the placement of a new implant. Why? Because as you can see over here, there's not enough space for an abutment and a crown to be placed.
So along with this picture, the considerations of the interocclusal space is one of the risks that we need to avoid, and the consideration of where the implant should be placed. Every implant, especially when we're talking about posterior implant, should be placed on the area that is going to get the most force, or there is going to be more damage to the implant, if I may say it that way, where the vectors of force is going to be the most. So those loading forces, typically in an implant, is going to be in the central groove as they are in the teeth. So for example, in mandibular implants, they will be placed in the central groove, and if in the initial guiding pin that we place in the drilling sequence, we have the patient to gently close down to see where that implant is going to hit the opposing dentition. In this particular case, in this picture, although the implant has to be removed, the implant, it is in the correct position from the mesial distal dimension with the opposing dentition, because that implant is going to hit the supporting cusp of the opposing dentition, which is the maxilla, right? So that is one of the considerations we have to remember.
Another consideration in this cases where patients have been missing teeth for a very long time is to make sure that we have enough interocclusal space, especially when teeth have super erupted. You need to see if modifications to the opposing dentition are even possible, even before you start placing your implants. And another consideration where you're placing implants all the way in the back in the second molars is to make sure that you have enough space to be able to bring your instruments all the way back there. The next dimension is going to be the mesiodistal dimension. So if you read all the literature from Smiler and Tarnow, so on and so forth, we know that in order to be able to replicate a papilla, we need to have enough distance from the shoulder of the implant to the adjacent teeth. Why? Because there's going to be an establishment of the biologic width that's going to happen 360 degrees around that implant. And even though with platform switch, we need to maintain certain distance from the shoulder of the implant to the teeth. Why? Because at least we're going to have about a 1.3 millimeters of bone destruction for the establishment of that biologic width. Now, most articles are going to tell you to keep a distance of about 1.5 millimeters. However, especially for the novice placers, we're going to recommend to maintain a distance of at least 2 millimeters. Why? Because measuring 1.5 millimeters is very complicated. Measuring 2 millimeters is going to be much, much easier, and if you have 2 millimeters to either side, it's going to be a much safer situation.
There's a question that from the previous slide in how much interocclusal space is needed, and does it depend on the restoration if it's a screw retained or cement retained? Perfectly, very good question. The first answer is how much interocclusal space is needed. Typically, in posterior teeth, you have to have at least 6 to 7 millimeters of clearance from the emergence profile of the implant to the opposing dentition. That means that from the bone and the emergence profile, you may have 2 more. So typically, about 8 millimeters from the crest of the bone to the opposing arch will be needed. Now, does that mean that is it better, or in that situation, shall we compromise to screw retain versus cement retain? Well, put it this way. when it's screw retained, the entire components, all the components are attached to as one piece, and you have a chimney that attaches directly that one piece to the implant itself. Now, the problem of this one piece is the same problem as you're going to have even in the crown cement retained, because it is, in many cases, it is not necessarily welded together as the porcelain is just completely fused to the metal when it's done. Sometimes the lab, instead of welding that together or sintering that together, they actually make the crown separate to the abutment. They put them together, they cement it, and they create a chimney hole in there. So granted, it's not necessarily the best way of doing it, but many labs do that. So they do a cement / a screw retain restoration. So the shorter the abutment, the more the torquing forces that the axial forces that it's going to receive. So even if it's a screw retained, you could have those axial forces damaging your short abutment, because you need at least 1.5 millimeters of that material, especially if you're looking at zirconium and what have you. If you're looking at Brockster zirconium, that's a different environment, because you can just have a little more leeway. However, if you have a crown and porcelain ceramic restoration, then you have to account for the thickness of the porcelain on top of that metal. So to make long story short, regardless if it's a screw retained or cement retained, you have to have at least 8 millimeters of space between the crest of the bone and the opposing dentition. I hope that answers the question.
Now, what happens if we have less than 1.5 millimeters in between your implant and the neighboring teeth? Well, what's going to happen is that establishment of the biologic width is going to destroy the bone that you can see all the way on the right of your screen. And because those fibers are not inserted on the implant, they're only inserted on a tooth, and you lose some of the fibers that get inserted on the tooth, then you're going to end up with a black triangle. So let's go now to the image in the center of the screen. What happens if you have a patient that just got debonded from orthodontics that is coming to let you know that she wants to get an implant? And when you measure the distance, let's say you're working with a 3.3 millimeter implant, and you only have, let's say, 6.5 millimeters. Well, it's not going to be enough bone to be able to have 1.5 or 2 millimeters of bone on either side. So what I would recommend is to send that patient back to the orthodontist, create adequate space so you can go and place that implant comfortably in that area. Now, another important thing, especially on this lateral incisor cases, is to make sure that both laterals are the same size. Because if they're not the same size, then the case is going to look different and it's going to look weird. So make sure that, let's say, they have a missing tooth on one side and they have a peg tooth on the other side, which is very common. Make sure that they also open enough space on the contralateral side that's going to be the same size as the side where you're going to have the implant. So when that patient gets the restoration on both sides, it ends up looking symmetrical.
Now, in the same concept, then the follow-up question into the distances, right? We looked before into the interocclusal distance. But what will be then the minimum distance that we will have to have, as Dr. Macsham mentioned, from a tooth? So you account for the diameter of the implant that you're going to be placing, plus the 1.5 in each side. So if the diameter of the implant is a 3 millimeter implant diameter, and then you have a 1.5 and a 1.5, that makes another 3 millimeters. So that 3 millimeter implant may fit if you may have a 6 or 6.5, but don't forget, the next thing that Dr. Macsham is going to talk about is papilla height. And then we have to have certain room for that papilla to grow to allow the space for those fibers to be created.
So in 1998, the Salama brothers came up with this chart that you're seeing right on the screen. Basically, what they saw is they gathered the information from a lot of researchers and put all that information into this chart, and they wrote a paper about it. So what they saw is that if you have two teeth, they need to be at least 1 millimeter apart in order for you to recreate a papilla that's going to be 5 millimeters in height. So they're looked at the proximity in between the two structures, either tooth to tooth, tooth to pontic, two pontics, teeth and implants, implants and pontics, implants and implants. And this article is still a huge landmark for implant dentistry. And then what they saw is how high does the papilla go in each scenario. So what we can see is that in the situation between a tooth and an implant, we must keep a distance of at least 1.5 millimeters in order to have a papilla that's going to be maximum 4.5 millimeters in height. However, in between two implants, we need at least 3 millimeters apart in order to recreate a papilla that's going to be 3.5 millimeters in height. So if you look all the way in the right side of the screen, those two scenarios are where it's going to be the most challenging scenarios to be able to recreate those papillas. In the scenario between a tooth and tooth, which is the natural scenario, I mean, you know you've got a proximity limitation of 1 millimeter. And the others, we don't have papers that are specific for those, but we know that between a tooth and a pontic is where you're going to have the most amount of height of the papilla. Between a pontic and a pontic is the next, and then between an implant and a pontic. So just keep those numbers in consideration and keep in mind that whenever you put an implant in place is where the scenario becomes more and more challenging. And we can see it right over here where two implants were placed next to each other. You can start to see that the platforms are not at the same level. You can start to see that there's not a peak of bone coronal to the platform of those areas. And if you don't form that peak of bone of 3 millimeters, you may end up with a scenario very similar to what you see here on the screen.
There is a very important concept that we have to look into when we look at two implants together, okay? The radiograph on the left side, as Dr. Mokhshaman mentioned, the platforms are not in the same level. And what that means is that the bone remodeling that will happen between one implant and the other will affect the implant that is more coronally placed. So if you have an implant that is more apically placed as the one in the central, we will have that central implant having more bone remodeling, and that bone remodeling will affect the platform of the neighboring side.
Now, we were talking a lot about the establishment of the biologic width. And Berglund and Lindy and all those people from Sweden did a lot of research on this topic. And what they saw is that this establishment of the biologic width is not just on the mesial and on the distal. This establishment of the biologic width happens 360 degrees around that implant. And why is that important? Well, because when we're putting our implants, we need to also consider the buccolingual positioning of those implants, okay? And when we look from the top, the positioning of two implants, we're going to see that we must maintain at least 2 to 4 millimeters of bone on the facial from the edge of that implant. So let's say that you go ahead and you place an implant and you have 1 or 1.5 millimeters of bone on the facial. Should I graft? Shouldn't I graft? They told me that only if it's exposed I should graft. Well, the answer is if you don't have between 2 to 4 millimeters of bone around that implant, you should go ahead and put more bone graft to the facial, especially on the anterior maxilla, if you want to recreate a nice emergence profile, because that bone that you see on the facial is what's going to hold the soft tissues and create an aesthetic and a natural emergence profile for that restoration.
We're going to just take a quick pause just because we have to eliminate one thing, but we're going to be back to it. Okay, good. Now back in business. All right, so one of the important parts in here when you're looking into doing a bone grafting along the implants, if you do not have that measurement that was shown to you as a 2 to 4 millimeters from the buccal, almost nobody has 4 millimeters of bone buccally. So most of the cases that you do in the anterior segment, you'll be forced, or you will be, it will be most adequate for you to do a bone grafting procedure at the same time as you do the insertion of the implant. But what if we have no bone at all in the buccal aspect? Let's say those walls that you see right now on your screen of 2 to 4 millimeter width, they say we don't have it. And if we place the implant, if there is no bone around that those threads, and the threads are exposed, can we graft and can we do a membrane for a barrier and going ahead and be successful? Well, be careful, because that is not probably going to work in most of the time, because you need progenitor cells, and the progenitor cells will come from the periphery of the adjacent bone. So what I will advise is, or you to consider, is in those cases where you see that you're going to be placing the implant and you're going to have a lot of exposures of the threads, because of the lack of that availability of cells, try not to place the implant. Instead, go ahead and do bone grafting procedures, a ridge augmentation as we want to demonstrate to you, and then implant placement at a later time.
So let's think about the implants that we're going to be using in Guadalajara. So we talked last time that the C1 implant that we're going to be using, we talked about all the characteristics of it. You can go back to the previous lecture that we did a couple of weeks ago and review all that content. But remember the sizes. Remember that we're going to be using a 3.3 narrow platform implant. That's going to be the yellow implant. Then we're going to be using a 3.75 and 4.2 standard platform implants, and the 5 millimeter wide platform implant. So when you start thinking about that, and you start thinking about the spaces that you have and the amount of bone that you have, you can start choosing, well, I know the width of, or the diameter of my implant, and now I can choose the height for my implant. And based on that, well, if you have a situation where you're only missing one tooth and you think that you need 2 millimeters to the medial, 2 millimeters to the distal, well, which implant can I fit right in the middle? And the selection of that implant starts becoming easier and easier. Now, what if I have multiple implants? How much space do I need? Well, the math is the same. 2 millimeters towards the to the medial and the distal, where you have the teeth. In between the implants, you want at least 3 millimeters. And then you can go ahead and start selecting which implants you want. Another thing that you want to consider is the average size of a tooth. So let's say that you have an area on the posterior mandible that you're missing a couple teeth. Well, if you only have 18 millimeters, you may end up having one premolar and one molar, even though the space was a space for 2 molars, unless you go ahead and do orthodontic treatment or you extract the distal tooth to gain more space. You won't be able to do that otherwise. So just keep in mind to those numbers and write them in a paper. Put down the 2 millimeters on the mesial, the 2 millimeters on the distal, the size, the 3 millimeters in between the implants, and then start adding and subtracting out of your final space, and then you can choose and select which implant you're going to use, and also, of course, an implant that's going to be in enough diameter to hold the forces of, for example, a molar or a premolar.
So don't forget about the width of the clinical crown, especially in anterior cases. Make sure that you are able to measure the clinical crown, because if you're going to have a clinical crown of 10 millimeters in the posterior, for instance, a molar, and then you have a bone width of 3 millimeters or 4 millimeters, you say, oh, I can go ahead and put a narrow implant at 3.3 in a molar and have my crown emerge as like a potato on a stick, where the crown is too large for the implant. But don't forget that the forces or the vector of forces, those axial forces and the biomechanics of that, most likely is going to transfer into that narrow diameter implant, and is going to fracture to the pathway of least resistance, which is the connection or the level of the Morse taper connection. So as a rule of thumb, in posterior teeth, you should always look into the widest diameter, which is 5. In the midsection of the mouth, which is the premolar areas, you should be looking to place a middle diameter, which is 4.2 or 3.75. And in anterior segment in the mandible, those teeth, most of the time you're looking to put a 3.3. Whereas in the maxillary anterior segment, 8, 9, typically is going to go between 4.2 and sometimes if the patient has a wide crown, so you can put also a 5. Many times that also, if you're going to do an immediate placement of the implant after extraction, the socket will help you dictate that diameter that you're going to use.
So going back to the 2 to 4 millimeters of bone on the facial, the wider your implant, the more bone you're going to have to build either before you place the implants or at the time of implant placement. Many times, in addition to bone grafting, you need to do soft tissue grafting to help with that emergence profile. But if you don't achieve that growth of bone on the facial, well, you'll end up with a situation similar to this, where on the right side, you can see that the tissues are very thin, but on the left side, you can even see the translucency of that implant. Even more, if the implant is not placed on the right position, you'll have a lot of recession of those implants that are placed more buccally. And many times, the only thing that you can do with those are to take them out. Now, when you are trying to bring your implants back to a better positioning and putting them more towards the lingual, don't be too exaggerated, because that can also bring you problems where your implants are going to be non-restorable. So in this particular case, one of those implants had to be buried because the surgeon, in trying to overcompensate, he was placing that implant so lingual that a restoration was not able to emerge from that area. So always keep in mind that your implant should be placed with a prosthetic mindset based on where the restoration is going to be and how that restoration is going to emerge from the gums.
Now, when we're looking at anterior implants, especially in the maxilla, we're thinking about the highly aesthetic areas, and that's where many people that place implants don't want to play in these neighborhoods because they're afraid of a mistake is going to be very costly, because either the interocclusal distance, the buccolingual position, the mesial distal or the papilla, and the aesthetic profile that you can achieve. When we were training, there was an advice that was given to us is that if you're going to make a mistake, make it on the lingual. So most of our implants at one point in time were very lingual because we were afraid of making that mistake. I will avoid that comment for the moment, and I will ask you to please consider what Dr. Marcus said, the ideal prosthetic position of that implant. And the ideal prosthetic position is going to be that your implant in the anterior segment will emerge as maximum in the incisal edge of the teeth, and that is going to be for a screw or cemented retained restoration. And if in the lingual side, just at the level of the cingulum, but not beyond the level of the cingulum. How are you going to determine that? In the first drilling sequence, you're going to place your guide pin. You're going to take a radiograph, and that radiograph will tell you the mesial distal dimension. But clinically, you have to have the idea of where that emergence of that pin will be, and that pin should be emerging at the level of incisal edge, between the incisal edge and the cingulum.
Now, in some cases, that's not going to be possible because of the anatomy of the side or because of the positioning of the dentition on the opposing arch. So if you have to end up with a cement retained restoration, that's not a bad thing. Just make sure that you plan that ahead of time. It's not that you're doing it as an afterthought. Make sure that when you're planning these cases, you know that you may end up with a cement retained restoration, even though we prefer screw retained restorations for all the reasons that we mentioned last seminar, that there's not going to be cement and it's easier to retrieve, so on and so forth. However, if you need to end up with a cement retained restoration, it's still an acceptable type of treatment that we can still do in many cases where the anatomy doesn't allow us to do screw retain.
And for that cemented restoration, make sure that you have adequate length for your abutment. So how much is the adequate length in the anterior segment? To go back to Dr. Lopez's question before, the adequate length, think about the anterior tooth, number 7 or 8. They measure somewhere between 9 to 13 millimeters average length of a tooth. You account for 2 millimeters of restorative material, porcelain, zirconium, and combination of metal. Well, you will have an abutment that emerges an average of 7 to 8 millimeters from the crest of the bone to be able to have a good protection of the axial forces.
Now, how we were able to fix this case, we were able to submerge one of the implants with a connective tissue graft, creating a Pontic site and a cantilever restoration. That at the end, the patient was very happy, and we did not have to remove that implant, and she was able to be restored with the implants that were already placed.
So this is not ideal, but it's something that we have to compensate for.
Now, here it's a little bit difficult because it's a webinar, but every time we put this slide and we ask who thinks they can place an implant in this 8 millimeter wide ridge, and I'm going to say that 99% of the people raised their hand and said that that's a slam dunk, that's a beginner's case, so on and so forth. But just keep in mind, where is the position of that restoration supposed to be? Well, if you were to place an implant in that tori, in the mandible, that would be a non-restorable implant. That would be a bad idea. So what happened in this particular case? Well, we took advantage of that block graft. We knew that we were not able to place that implant exactly where it had to be placed. We took a block graft out of that tori, and we transferred that block to the facial to recreate the bone exactly where we needed to. We filled the gaps with some particulate bone graft and covered it with a collagen membrane. So when we came back, we had transferred the bone from the lingual to the facial, and an implant was placed in the correct prosthetic position and was fully surrounded by bone and nice keratinized tissue.
Now, GBR, which is translated to guided bone regeneration, which is bone grafting in order to obtain an augmentation procedure, it can be performed simultaneously with implant placement in the presence of dehiscences and or fenestrations. What that means for us is, in this particular case, we have an implant that needs to be placed in conjunction with the bone grafting. Why? Because, as we said, the best prosthetic position for this implant was going to be the central ridge. And you could see a dehiscency here. Now, the dehiscency here doesn't mean that we cannot place the implant. It means that we have progenitor cells because the implant is placed within an envelope, within a housing of bone. And even though we have threads exposed, that housing of bone can result into a positive effect for us. Because by doing a bone allograft, which is the one that we recommend, again, as we reviewed last lecture, allograft, mineralized freeze-dried bone allograft will be the best possible bone graft that we can typically use, or autogenous if you want to grab autogenous, but we will review that on site. Once the bone graft particles are placed in here, then a collagen membrane is placed on top of that, and we achieve primary closure. Primary closure is important when we do a lot of ridge augmentation, because that will protect the graft and prevent the epithelium to invaginate into that area. Now, the tension that we have in that flap, sometimes mistakenly, we think that by constricting and pulling harder on the flap and achieving primary closure that way, we may think that the flap is getting closed with one intention. And yes, to the naked eye, it may look close. But if we were to have blanching on those sutures at the moment that we approximate the flap, that means that we are constricting the vasculature on that flap, and we most likely have necrosis and opening of the wound. So it's very important to remember a tension tension-free flap. And we'll show you on site how to do a periosteal release to accomplish that.
Now, another thing that you can observe in this particular picture on the right is the combination of sutures that were utilized, a horizontal mattress suture to approximate the tissues and bring them in a coronal direction, and single interrupted sutures just to bring the edges of the flap without any additional tension, one next to the other, and those sutures should stay there for at least 2 weeks while the tissues mature and we have strong collagen fibers in that area.
Now, don't worry too much about this. Like, well, hold on, you haven't shown me how the horizontal mattress works. Don't worry about it. Just think about the specific principles that we saw at the beginning. Horizontal mattress, when you hear that word horizontal mattress, means we're going to create a tension-free flap. And we'll show you how to do it on site.
And we'll practice a lot of those sutures over there. So if you have these 3 clinical scenarios over here, that's why having a CBCT is very helpful. Well, you'll think, well, if I place that implant in here, am I going to have enough bone to place that implant? Well, you should probably graft prior to placement. Well, if you have a scenario like the one in the middle where you can place that implant and you end up with a small fenestration where you still feel comfortable that that implant is going to be stable and we're going to have adequate primary stability for that implant, you can place that implant and graft at the same time.
Don't forget in the picture in the center, a fenestration means that the implant is inserted and the tip of the implant is showing through the facial aspect. However, in the coronal aspect of the platform of the implant, we do have adequate bone. But if you see, that fenestration is within the housing of the bone. So that means the progenitor cells will help us to grow if we do grafting predictably in this scenario.
Now, the Hisensis, you can still graft around the Hisensis as long as the implant is placed in the correct position and it's within the housing of the bone.
And what it means, the Hisensis, means that we don't have any buccal plate remaining as it is in the picture on the right. You see that the implant was placed, is anchoring bone, but we have a collapse of the buccal bone to a certain level throughout the implant from the crest of the platform of the implant to the apical extent. That adhesive could be grafted for as long, as Dr. M said, if the implant is within the housing of the bone.
And the fourth dimension, that it's a dimension that not a lot of people talk about, is angulation. You might have the center of that implant in the right position. Buccolingually, you have all the space that you need, and you're right in the middle of the ridge. And apicocoronally, you're putting the implant exactly where it goes. However, your angulation needs to be checked all the time. So whenever you're placing an implant, check mesial distal, buccolingual, and then once again check for that angulation. Because if you're only checking for one of those dimensions at a time, you're going to lose that fourth dimension. You're going to lose that angulation. And you may end up like this situation where an implant was placed and that implant had a lot of problems when that patient smiled, but buccolingually, it was in a good position. Look at that x-ray. We have enough distance between the implant and those teeth.
Mesiodistally.
Mesiodistally. Buccolingually, there was some bone. However, the angulation of that implant was incorrect. Okay? Look at the emergence of that implant. It was completely incorrect. Even though if you were to look at the picture in the middle, you were like, oh, it's not so bad. You could put a cement retained restoration. It's not going to be screw retained. However, when you put a pin directly on that implant, you can see that that angulation is completely incorrect.
And for that, we look at the studies from Funaro and co-workers, which illustrates this picture. And this is related to what we were mentioning before. What is the ideal position of an implant? What are the acceptable positions? And what is the wrong position in the anterior segment? So the ideal position is between the incisal edge and the cingulum. Acceptable positions will be slightly off buccally from incisal edge, but in a way that you still be able to correct with a maximum of about 20-degree angulation to a cement retain restoration. And another acceptable position is going to be if the implant is placed directly under the incisal edge. However, what's wrong is that you surpass more than 20 or 22 degrees buccally, because that makes it very challenging, as it is this case. Another situation here, whenever possible, you're going to be able to place the implants together and still be able to manage to create enough bone to support the papilla in there.
Now, as we've been saying this along today and last time. Yes, you want to screw retained restoration as much as you can. However, if it's not possible, it's not the end of the world. Cement retained restorations are still a great restorative option. And if the anatomy calls for you to do a cement retained restoration, just make sure that you remove that cement really, really well. So we talked about this last time. In order to satisfy patient and clinical satisfaction in the aesthetic appearance of the implant restoration, you have to take those 4 dimensions into consideration. Why? Because if the patient's not happy, because if the clinician's not happy, what you need to do is you have to come back, you have to remove those implants that are not placed properly, you have to rebuild the bone in order to gain again tissue. As you can see in this picture, we lose a lot of tissue, we lose a lot of bone, we lose tissue and bone around the adjacent teeth that can bring you to a lot of problems.
What we're going to present to you now is how this case is managed from the perspective of implant failure. We all will experience that, experienced clinicians, new clinicians, that we will all experience at one point the failures. And this is going to show you a case management of this implant. So we obviously, evidently, from the picture on the left, in black and white right now, we have the adherency. When we reflect the flap, the implant, we notice that there's no bone, and we had to remove it. So that is the traditional way of dealing with peri-implantitis and failed implants and these type of circumstances. In the next picture, we'll see that when we remove the implant, we have 2 choices. Either a choice of doing nothing and let the tissue grow by itself, and restoring the implant site temporarily with either an Essex retainer or a removable prosthesis or a fixed Maryland type of temporary bridge. Or we will have a choice of doing a bone grafting. In this particular case, we elected to choose to do nothing with the bone graft and to have the tissue grow on top of that defect. Why? So in order to have more tissue to do a proper reconstruction later. How long do we have to wait? Minimum of 2 months for that maturation phase of the tissue. So when we re-enter that site, obviously re-entering that site, what we're going to see is that residual defect from the implant failure. You see, there's no bone grafting was done at all in that case.
Now, if you think of what we were talking about, socket grafting and placement of implants on sockets, the difference between this scenario and a fresh extraction socket is that here we have all the tissue to be able to achieve primary closure without any complications. So what you can see here is that once we have elevated that flap fully, the next thing is you're going to be able to place that implant in the proper position. And this picture on the right shows exactly what we've been talking about, that housing, those walls of bone on the mesial and the distal that are surrounding that implant. Now, this is a very challenging, I would say it's a very expert type of case where you're rebuilding almost 100% of the bone on the facial of that implant, where you're not using collagen membranes, you're using titanium structures to be able to rebuild not only that bone on the facial, but you want to rebuild, as we mentioned, between 2 to 4 millimeters of bone towards the facial. So when you end up with a nice restorative solution.
Now, in this particular case, you have 2 choices. The choice as we elected in this case, to place an implant and to go ahead and use those titanium structures to create the bone and to house the bone, with the biology in mind that the implant is within the housing of the bone, mesial and distal, as it was told, as we told you. If the implant were to be positioned beyond vocally of those walls, then we will have to avoid doing this and do grafting before. Now, the second choice of treatment will be not to place the implants at this time, do the proper bone grafting procedure, rich augmentation, either utilizing a titanium structure or not. But now that we, as we said before, that we have the soft tissue that was created in there, we will be able to have manipulation of that tissue to obtain primary closure.
As you can observe over here, that implant is not covered with bone on the facial, maybe just a couple of threads on the apical portion. You can see there's also a fenestration, which is a window on that lateral incisor. However, when you put that mesh on top of that area and you rebuild that bone, you let it sit enough time underneath a collagen membrane that gets placed on top of that mesh.
This is the type of collagen that you will be using. You see how the collagen has draped on top of that mesh.
Now, the picture that is not shown over here is how those tissues were approximated. A periosteal releasing incision had to be created in order to allow the volume of that bone and the volume of that membrane and the volume of that mesh to be placed in there. So once you remove that mesh, you can access that implant, and now you can see that that implant is fully covered with bone 360 degrees. And as I mentioned, sometimes additional soft tissue grafts are done to recreate the buccal contour of tissues and create an adequate emergence profile in that area.
And in this case, the connective tissue graft that was done, it was harvested from the area of the maxilla in the part of the tuberosity. So thus we have a very thick piece of tissues. And in this case, that tissue tuberosity was very, very thick. So that way we will be able to put it on top of that thinner bone that was there.
And the next part is the management of the tissues, where you take initial impressions so you can go ahead and do some provisional restorations. Sometimes we decide to do additional connective tissue graftings in order to increase the thickness of the tissue for those of you in the more advanced level, and those of you that chose and elected to do soft tissue grafting around implants. We will teach you how to harvest connective tissue grafts. We'll teach you also how to insert either connective tissue grafts or allografts into the spaces on the facial, so you can recreate the structures that your patients are missing.
So in this particular case, a very simplistic approach to introduce that tissue grafting once it's harvested is to undermine the buccal aspect. I won't say a flap because it's not a flap, just undermine the buccal aspect of a pouch or where the abutment sits, and just introduce that graft and suture it in the apical extent. That's all is needed to be able to pull it down and to get the bulk that we want for better aesthetics.
The maturation of this type of tissues is between 2 to 3 months, and then you can start recontouring the tissues. Make sure that when you're recontouring your tissues, you use your subcritical contours. Make sure that your contours are there. One of the advantages of this MIS implant is that that subcritical contour is included on all your prosthetic parts.
That, if you remember, that subcritical contour that is obtained from the edge of the platform of the implant in your abutment onto the emergence profile. So the bottom part of that curvature that you see in red in the screen, the left screen, the coronal aspect of that curvature is actually sitting at the edge of the gingival margin. So your subcritical contour is that concavity that is on top of the platform of the implant and beneath the gingival margin, with the main reason of having the tissue invaginated into that concavity for protection of the bone remodeling and biologic width.
And always remember this phrase: the subcritical contour is going to be critical in recreating the facial tissues, in allowing space for those tissues to show up and maintain their inadequate thickness. Because as you start pushing the tissues to the facial, you're going to start to have some recession. From here, what it was done is a copy of that ideal temporary was done, and a customized impression coping was picked up from that impression with some GC resin. So when you take your final impression, you can capture exactly the anatomy that you have created with your provisional restoration. A abutment is placed, and a final restoration is done in conjunction with a partial veneer on that other tooth, so we can go from before we started with a very big problem into a very nice situation where the patient is very, very happy and very pleased, and also us as clinicians, we're very pleased with that situation.
Now let's talk about how to correct our mistakes as they are happening, as long as we acknowledge that they're happening. And that correction has to be done through the drilling sequences. One of the boards that's actually very important board to use is called the Lindemann board. This board is a side cutting board that helps to correct the positioning of the implants after the pilot drilling. And what that means for us is like this example. We have a drilling parallel to the clinical crown could cause a root perforation. So we think that we have in the best prosthetic position in here, and all of a sudden we don't. We are approximating the apical part of a root.
And that's why on your drilling sequence and your drilling protocols, which is something that we reviewed last time, we mentioned, and we're going to teach you not to drill to full length. We're going to start drilling to 6 millimeters. That way we can do all the corrections before we're at full length. One of the things that we want to make sure is that when you go back to your practice and you start placing all those implants, you run into the least amount of problems. So we're going to go very, very carefully into some protocols on how to avoid problems, how to correct the problems, or how to correct the situations so you don't run into problems. So drilling to 6 millimeters will avoid the situation, because you automatically know that if you keep on going, you'll hit that root. So right at 6 millimeters is where you can start doing your corrections. Now, let's say you already went all the way down to your final depth and you need to do corrections. They can still be done, and the Lindemann burr is a great solution for that. Okay, so you can use your Lindemann burr. You'll put pressure towards the side where you want to be cutting. It's a side cutting burr, and it's very, very helpful. Try to use your Lindemann burr at your initial stages, because once you have widened that osteotomy, making corrections becomes more and more difficult.
Now, when we're drilling, I want to make you a very important tip that I will remind you right on site. When we drill implants, we don't drill with your wrist or with your fingers. That's a typical mistake. Because if we end up drilling with the flexibility of our wrist and just directing our implant with the wrist, as the wrist moves from left to right or top down, the implant will change direction, the drilling will change direction. So one of the important tips in placing implants or corrections is going to be to lock your wrist and your fingers in one particular position, the most comfortable, and then drill and direct the implant with your forearm. Only with the forearm, but not with your wrist. The wrist is locked, and when you do the correction is done as a one single element, including the forearm, locked wrist, and locked fingers.
And always remember that your thickest cortical plates are going to push you to the opposing direction. So on the maxilla, the palatal is always going to push you towards the buccal, and the mandible, the lingual, is always going to push you towards the buccal, which will bring you to a lot of problems if you don't take those things into consideration. So drilling with pilot drills, using the Lindemann burr, and drilling very slowly during sequence, especially at your initial stages of your implant placement career, is going to be very, very important.
Also, many times people think about making correction is making pressure only in the osteotomy. But the reality of it is that putting the pressure, as Dr. McShammer just mentioned, it will push you to the pathway of least resistance, especially with those cortical plates. So therefore, the corrections sometimes are done before we enter the osteotomy. That means that we have to keep the drill running at the speed of what we're going to be drilling, and we gently touch the bone that we're going to be drilling away. Not pushing on the bone, let the drill do its job of drilling the bone away. So instead of introducing the drill, and once the drill is on the osteotomy, start pushing the pedal to drill, no. Keep the drill outside the osteotomy, let it run, and then as it's running, you correct that osteotomy.
So here you can see how the osteotomy was corrected with the Lindemann burr. Now you can go to your final drills and final widths and go ahead and position that implant in the correct position. So Lindemann burr is going to be a very helpful tool. Always have it on your kits, always have it handy because it will help you avoid a lot of problems. We talked a little bit briefly about this type of situation, when to do one-stage or two-stage procedures. One stage is when you put your healing abutment right on the implant, especially in your initial stages. If you're going to do any type of grafting, do a two-stage procedure. If you have plenty of bone on all directions and the patient has excellent oral hygiene, you can go ahead and do a one-stage. There's a lot of research that shows that it's equally successful to do one stage versus two stages. However, we would recommend you to be very cautious, especially if the oral hygiene of the patients is not ideal, or if you're doing any type of grafting. And when you're doing your second stage and putting that healing abutment, always take in consideration the amount of keratinized tissue that you're going to have in that area. So pristine oral hygiene, non-smokers, adequate primary stability, and no non-grafting misperformed, go ahead and put a healing abutment. We'll avoid one surgical procedure for you and for your patients.
Other than that, you will choose to do a two-stage where you're going to do submerge of that implant by putting a cover screw and just achieve primary closure.
Now, we're going to move to a completely different category right now. We're going to get into the maxillary sinus. And for those of you that are on the intermediate and advanced levels and chose to do maxillary sinuses, we're going to be working a little bit more in depth with you in Guadalajara, sitting and reviewing a lot of cases with you. And for those of you that are on a beginner's level, just keep in mind that right now you're a beginner, but you're going to be an intermediate or an expert hopefully pretty soon. And don't think that this is going to be too advanced and too far for you, because our goal is to be able to bring you to this level pretty soon. So let's talk a little bit about the maxillary sinus. And we're not going to talk about the anatomy. We talked about all that stuff last time. We're going to talk about treatment. What do we do in different clinical scenarios, and how do you approach the sinus in different ways? So our first scenario is when you have 10 millimeters of vertical bone height, you have adequate bone width, you may need to do some bone grafting or not on the buccal if you don't have enough bone width. As we said, our ideal implant height is going to be 10 millimeters. Very simple. You could do a conventional implant placement. Don't even think about sinus. Let's say we said last time that you had to be a millimeter away from the sinus. Even if you were to touch that sinus membrane will heal around that area. It won't create any complications. Your implants are going to be sterile. You can go ahead and place those implants very easily right on the sinus or right next to the sinus and treat it as a conventional type of treatment. And in that particular case, even if you have good bone, you can go ahead and put some cover screws or put some healing abutments depending on your preference, depending on the patient's oral hygiene or the way of that they smoke or they don't smoke. And you don't even need to manage it as a sinus.
So in that conventional treatment, we remember that is minimum of 10 millimeters. So that will be our goal, right? Our goal will be to achieve that 10 millimeters. Why? Because that is the average implant length, and we know that beneath that implant length, shorter implants, the success rate, even though some studies say that the success rate is very similar to those of a regular length, we see a lot of meta-analysis in the literature that indicate that shorter implants may not be as successful in all cases. So our goal is to achieve that 10 millimeters. Now, scenario number 2 is when we have a deficient sinus. And if we are going to be placing an implant that is 10 millimeters, but we only have 5 millimeters of height and not 10, what is it that we need to do? Remember, now the next number that you have to remember is 5. With 5 millimeters, we can choose to go either in one direction to try to do the sinus elevation in a lateral or external approach, or we can have elect to do an internal approach. So 5 millimeters in the literature says that we could still do predictably the elevation through the osteotomy, which is the internal approach.
Now, what are going to be some of the things that are going to guide you towards doing a vertical or sinus lift? Part of it is going to be the anatomy, the axis. Let's say you have a second molar, and doing a window all the way in the second molar on a patient that doesn't open a lot becomes very complicated and very difficult. Many times you might prefer to go through a vertical approach. Now, Summers introduced his osteotomes techniques, and he introduced actually 4 papers where he described his technique in different ways, that you can graft the sinus before you place the implants, that you can graft the sinus at the same time with implants, that you can put bone graft or not bone graft. What we're going to recommend is that if you're going to use the Summer osteotomes, what you do is you do it on scenarios where you have between 5 or where you have more than 5 or less than 10 millimeters, and you can either use the curved or the straights. My preference is the straights because the curves tend to bend and the forces of your mallet are not directed straight to where you want them to be, and you can lose your angulation and your direction with those type of osteotomes.
The curved osteotomes, so you understand, are used to get around the opening of the patient's mouth. If the patient is limited opening and we cannot access more posterior as we're working, we use the angle osteotomes. But again, whenever possible, we use the straight osteotomes. And the straight osteotomes, as you could see in the right side of the screen, have different lines. And those lines indicate the length of the osteotome to that line. It starts typically with a line of 6, 7, and in 1 millimeter increments up to 10. And then we use a mallet. And the mallet is going to help you to push that osteotome to the level of the wall of the sinus, the floor of the sinus.
Now, something very important is to stop your drilling 1 millimeter short. Okay? You might need to take multiple x-rays. CT scans are very, very helpful in determining the length. Digital dentistry and doing surgical guides can allow you to stop right at a millimeter short if you're doing a guided type of procedure, and that way you'll stay safe. Once you have drilled to a millimeter short from that sinus, what you're going to do next is you're going to start packing some bone, about 1 millimeter or 2 of bone into that osteotomy, and with light forces with the mallet, you're going to push the bone into the sinus. And then you're going to start introducing more bone and tapping more bone. Now, something to keep in mind that's very, very important is never bring those osteotomes into the sinus cavity. Always stay away from the sinus cavity. The only thing that goes into the sinus cavity is the bone. Your instruments should not go into your sinus cavity.
Now, there are other techniques that we can review for internal sinus elevation, such as the use of piezo and what have you. We're going to describe that in a moment. But in this picture, what you see in the picture on the left side, you see the little segments of bone that used to belong to the floor, now they were elevated. Remember the rule of thumb. Do not penetrate the sinus with your osteotomes. Let's say you want to increase your sinus to a minimum of 10 millimeters, right? But you only have 5. So what you do, you introduce the osteotome, and the first time you introduce your osteotome, you end up at 4 because you have that extra millimeter from the sinus. So your next line or your next goal is going to be to bring that osteotome to 5. Once you leave once you bring that osteotome to 5 millimeters, you have already fractured the bottom part of the sinus floor, and from there on, you remove the osteotome, place more bone particles, and the next tapping sequence for you is going to be until 5. You remove the osteotome, you pack more bone, and the next sequence is going to be until 5.
Now, when you're tapping, once you fracture that wall of that floor of the sinus, your tapping needs to be a lot more gentle.
Yeah.
Why? Because you don't want to bring that instrument all the way in. If you tap, then you can go all the way in. And you can see in this clinical case where one implant was placed without any sinus, and the other implant was done with an osteotome lift, and you can see the floor of the sinus, and now you can see the bone that is surrounding the implant fully around that area. We recommend that you allow those implants to heal about 6 months. We're very conservative in our protocols after grafting. Don't try to go early with any type of grafting. Always allow them to heal properly.
Now, the next step is to do, if we elect not to do the osteotome,
there's other systems that you could also use for vertical approach, like this intracrestal sinus kits that you're going to be able to use if you want to, where you have those stoppers that will help you stop right next to the floor of the sinus, and you can see how those stoppers help you create that osteotomy and stop right where you need to be, so then you can go ahead and use the next drilling sequences. That way you don't transfer all the way to the sinus. Something that we use all the time is periodontal probes to measure the distance where we are inside the osteotomy. Once you start drilling and you perforate into that sinus, you will feel a drop, whether it is with your osteotomes, your summer osteotomes, or with your intracrestal sinus kit. And you're going to have a lot of stoppers, and that way you can keep on increasing the distance. And then with condensers or with, you could grab at this point your summer osteotomes, you can start pushing the bone into the sinus, creating your sinus lift right in that area, and then you can go ahead and insert your implant, and you can see all the way in the right how that implant is fully surrounded with bone in the right position.
Now the question here will be from you, what happens if by mistake I advance my osteotome or my condensers too far deep into the sinus and I break the membrane of the sinus? What do we need to do? Well, we need to treat this perforation as a oral antral possibility of oral antral fistula. We don't want it to happen. So what we need to do is we have to abort that procedure. What we need to do is place a very end tip of a collagen tape, a collagen plug into that socket, cut a very small collagen membrane. So we put the tip of that collagen sponge into the tip of the perforation. Then we place a little membrane on top of that collagen. We fill in that osteotomy with bone graft. We put another collagen membrane on top of that, like a sandwich technique, and then we put the flap together. If it happens, we'll help you manage that, and we'll review that on site.
Now, the Action Cube, which we're going to have available in Guadalajara as well, also has a set of tips and a set of programs for you to be able to use the intralift technique, where, as you know, even if you touch the membrane or soft tissue with some of these tips, they will not cut through soft tissue. And we move now to scenario number 3. So let's say you were to perforate that membrane and you don't want to abort your treatment. You can always come to a scenario number 3 and open a window, or directly, if you don't have enough height, you have less than 5 millimeters, you have between 4 to 10 millimeters, it's adequate to do a lateral sinus lift, where what you're going to do is, if you have between 4 to 10 millimeters, you're also going to be able to place your implants at the same time, because those between 4 to 10 millimeters of bone are going to give you enough stability Many times, depending on the anatomy or depending on how comfortable the surgeon feels doing one procedure or the other, is that you're going to be able to place your implants or not, or the type of procedure that you're going to elect. So in this case, you mark your window, make sure that the base of your window is as close as possible to the floor of the sinus, and the top of that window is going to be as close as possible to the apex of your future implant. So measure from the crest of the bone to the top of that window, and if you're placing a 13 or a 14 millimeter implant, you want that to be the height of your window. Obviously, if you're doing this type of procedures, we recommend that you place implants longer than 10 millimeters.
So in that regard, the technique calls for being able to place your window above the sinus floor.
And look in this image, there's only one vertical incision, and it's on the distal, okay? As we were talking about flap designs, we keep one vertical on the distal. For those of you that are starting, you might want to put also a vertical on the mesial. It's going to make it easier for your axis. Just keep in mind that you're going to have to suture that vertical, and it's going to leave a scar for your patient.
So the way that this works is, how do we open the window?
So you have three ways in which you can open the window. You can do a hinge by doing decortications on the most apical portion or the highest portion, and then you are going to be able to flip, keeping that little piece of bone still available in there. Then you're going to have the elevated osteotomy, where you're going to do a full window. You're not going to detach that that piece of bone from the membrane, and then we're going to have to push that membrane completely up with that little piece of bone in place. Or the complete osteotomy, which is the one that we're going to recommend, where you remove fully that piece of bone. And why do we recommend that? Because many times with that hinge osteotomy or that elevated osteotomy, you might have some sharp edges on that piece of bone that can perforate your window. If you remove completely that window from your Schneiderian membrane, then you're going to be able to assess that membrane. And if you have a perforation, we'll teach you how to fix those perforations with some collagen membranes, so you don't have to abort those procedures.
Typically, fixing those restorations involves placing the collagen membrane inside the perforation, and you will see how that membrane adapts very well into that. Now, we do have a sinus curettes, and the sinus curettes look like spoons that gently around the border of the window will help you to slowly elevate that window from the bone. And this is like a full thickness flap elevation. It's just the difference is that we're elevating the sinus membrane, which could be very thin, and this is where the perforations could occur. We will review the specifics on site, so that makes sure that you're trained and you know how to do it.
Now, just the way that you were taught to always put your elevators on the bone and never separate it from the bone, particularly on lateral sinus lifts, this is going to be very, very important. You want to put that curette all the way on the bone. You don't want to lift it from the bone, because if you lift it, you're going to encounter a perforation. Remember that that Schneiderian membrane measures less than half a millimeter most of the times, and if you perforate it, then it's additional work, it's more materials, so on and so forth. Another thing that you want to remember is, if you look at this window, it goes as far mesial as possible. You want to really detach that Schneiderian membrane from your anterior wall, and you also want to detach it from your interior wall, because those are the walls of bone that are going to feed that bone graft with cells to replace that bone graft with your patient's bone. So then you can have that process of osseointegration around your implants.
So again, going back to the internal elevation, if you perforate the internal elevation, we will be ready to use this technique to save the procedure, to elevate the membrane from the lateral window, and to do a repair on the membrane by using some collagen membrane to be able to close that sinus perforation.
And also keep in mind the anatomy. The submillunar hiatus is the exit of the sinus that will feed all the content from the sinus to the nose and exit it from there. Remember to keep all your surgery within half of your sinus, which is called the surgical portion, and away from the physiological portion, because you don't want to block that exit. And the moment that you block that exit, you're going to start having infections that you cannot control because there's no drainage in that area, and that's a direct referral to an ENT. So always stay in the surgical portion of your sinus.
Now, questions that arise typically from clinicians or patients is, well, I'm afraid that you're going to go into the sinus. The maxillary sinus is a separate cavity from the nasal sinus. And what the main function of that maxillary sinus is to receive the post-drainage that happens from the clogging of the nasal sinus and the modal sinus in the front, draining into that space as a spare chamber. So actually, by elevating the Schneiderian membrane, by performing a sinus lift procedure, we will minimize the antral volume of that sinus, which in turn may favor the drainage, because the drainage is not until you see that red arrow. So once the mucus reaches that is when it drains back to the nose. So we will be minimizing that chamber. So actually the answer to those questions to the patients is like there is a minimum risk, and they may favor the drainage of your sinus infections when you have one.
So going back over here, we go ahead and we do a complete osteotomy. We remove the wall of bone, and we can see that there's a perforation over there. Don't be worried about it. Something to do after you do a perforation is to stop, analyze that perforation. You want to separate the membrane 360 degrees around that perforation. Perforations are going to happen 44% of the times, unless you start using a piezo machine, which we'll talk about it in a second. If you're within that 44% of the times because you didn't use the piezo, we'll teach you how to fix it with a collagen membrane. Make sure that you have at least 5 millimeters of collagen membrane surrounding the periphery of that perforation. Or if you use a piezoelectric machine, you can significantly reduce to the single digits the amount of perforations that you're going to have on the sinus. Pack your bone really, really well. We recommend that you don't do the perforations unless you have packed the bone, the drilling for your sinus. You might waste some material. However, that's going to protect your Schneiderian membrane from breakage. You don't have to drill all the way down. You just have to perforate that floor of the sinus when you're doing your drilling. And then you're going to go ahead, pack more bone, place your implants, pack more bone, and Tarnow and Fromm have shown that if you place a collagen membrane on the outside of your window, you're going to have more successful implants in your sinus. So we let those implants heal underneath the tissues on a two-stage approach for 6 to 8 months before we go ahead and uncover those implants and we go ahead and load them.
So the last scenario, scenario number 4, is when we have a vertical bone height of less than 4 millimeters. So actually, scenario 3, the one we reviewed before, the only difference between that scenario and this one here is that in the scenario before, we have enough native bone to be able to stabilize the implants and place the implants simultaneously with the sinus elevation procedure. Whereas in here, in scenario number 4, the vertical bone height is less than 4 millimeters, and therefore will be forced to be able to do the sinus elevation prior to a bone implant placement. The picture on the right side shows the cross-section of the maxillary sinus. What you see in that cross-section is after the line of the bone, you see in the internal part of the sinus, you see radiopacity that denotates the Schneiderian membrane. And if you were to place a 10 millimeter implant or a 5 or a 13 millimeter implant, you will not have enough threads to be able to stabilize in that native bone. So therefore, you run the risk when you place the implant in less than 4 millimeters that the implant is going to be dislodged during the remodeling into the sinus.
However, when you're designing your window, design it with the size of the implant that you would desire to place in there from the beginning, because you want to position that more apical portion of that osteotomy where the apex of that future implant is going to be. Another important thing that is very important from this slide is you're going to elevate that membrane all the way to the right corner on the upper left side of that red box, because you want to open all that bone and give access to your bone graft, because that bone is what's going to feed your bone graft and what's going to allow the cells to transfer to the bone to grow new bones so you can place implants in there.
Typical mistakes when we elevate the sinus is we do not elevate the anterior portion of that sinus, so we stay shy from it. We do not elevate the palatal part of it, and we do not elevate the posterior part of it. So you have to ensure that you do fully elevate the anterior, the medial, which is the palatal side, and the posterior.
And in this case, you can see that how a flap was elevated to access that lateral wall of the sinus. As we said, we choose a complete osteotomy, so then we can go with our instruments in that area, always keeping in mind that we want to stay within our surgical portion. We don't want to block that physiological part of the sinus. And in this case, we were able to elevate the membrane without any perforations, which is what we want to do. We don't want to have any perforations if we don't have to. However, they do occur. They do occur in a big percentage unless you use some piezoelectric machinery, which not everybody's going to have. However, you're going to be able to try and test that type of equipment once you're in Guadalajara. From here, very simple, make sure that there's no perforations. Sometimes you can do a Valsalva test, which is a 100-year-old test where you block the nose of your patient and you ask them to blow. However, be very, very careful with a Valsalva test, because some patients might blow very hard and then they can create a perforation on that Schneiderian membrane. And if there's no bubbles and there's nothing in there, sometimes people recommend that as a precaution, you do put a membrane in there. However, it's not necessary. You can go ahead and put your bone graft, close that window with a collagen membrane, put some sutures in there. We would recommend some horizontal mattress to close and approximate the flaps, some single interrupted sutures to bring the edges of the flaps together. And now, guess what? You're in a scenario number one again, where all you have to do is a single implant placement without thinking of additional procedures. Just go ahead, place 10-millimeter implants in that area, and that's the end of the story. Very simple procedure once you have created adequate bone for those implants. So what should we do if this, in this type of scenarios? If the source of the alveolar ridge deformity is the natural remodeling of the alveolar ridge after the removal of a tooth, well, do lateral and or vertical ridge augmentation. If the source of the alveolar ridge deformity is the sinus pneumatization, then do a sinus augmentation, whether vertical, lateral, with or without piezo. You're going to learn different techniques and you're going to be able to choose which one you like the most. Or you can have a combination of a natural remodeling of the ridge and the sinus pneumatization, where it becomes even more complicated because you would have to do a combination of procedures of a sinus augmentation and alveolar ridge augmentation at the same time. And as some clinicians say, take one miracle at a time. You may need to do it in multiple procedures. You don't have to do it all at once. And always keep in mind, if you have 10 millimeters of vertical bone height, you don't need to do any type of sinus lift procedure. If you have between 5 to 10 millimeters, internal sinus lift is adequate. Between 4 to 10, external sinus lift is adequate. And if you have less than 4, you may need to do your external sinus lift first, and then wait before you can come back and place your implants.
So by now, we have reviewed the basics of flap design, implant placement, and sinus anatomy, as well as sinus elevations. Don't worry if you find this a little bit too basic for those of you who have done it. We will review these concepts over and over again once we're on site. this is just the first round, so that way you'll be able to get acquainted to the things that we will be encountering on site.
Now let's talk about edentulous patients, and this is going to be for pretty much all our levels, even the beginners that are going to be doing overdentures in the mandible, for our intermediates and our advanced. So when you're restoring the edentulous ridge, you need to start thinking about solutions on how are you going to be restoring that patient. And you have, of course, removable and fixed solutions. Just keep in mind that when you're talking about removable solutions, you have full dentures and implant-supported overdentures, which with full dentures, you're going to reduce the chewing capabilities of your patients between 10 to 30%. That's why implants are going to be so important for the quality of life of our patients, because just by adding some implants, even for an overdenture, we can increase their chewing capabilities up to 60%.
And that is irremovable.
So just think about all the nutrition that your patients can get with having some implants to help them support a removable prosthesis. So let's talk a little bit about mandibular overdentures. And this is just going to be an overview. Over there, we're going to separate ourselves in groups and go a little bit more in depth. So when you have a edentulous mandible, always think about your anatomy. Why? Because you want to stay away from that inferior alveolar nerve, and you want to be very, very careful with those mental nerves. Whenever you're going to raise a flap, most of the time you're going to find a very thin ridge that you're not going to be able to place implants in there. Therefore, performing alveoloplasty to make that ridge flat is going to be very, very important. And you're going to have it on your treatment planning sheets and your motor sheets. Straight handpiece at 30,000 revolutions per minute is with a lot of saline irrigation. It's going to be very helpful to create a table that's going to be flat in a thicker occlusal surface, where now you're going to have enough space to be able to place those implants of adequate width and length in that patient.
So if you see the picture on the left, how you start with a knife edge ridge, and by reducing that ridge to more of the core base of that bone, you will be able to get that width of the bone that will allow you to place the implants. This is going to be done, obviously, in patients that have enough height, and we will be able to determine that through a radiographic examination and a CT scan evaluation.
And now, talking about flap design, make sure that you bring those mid-crestal incisions far back. Many times you go all the way to your pads. That way you can have good access to bring those thick burrs, and you don't damage your flaps.
Dr. Markshammer alluded to be careful with your foramens. When you're looking in the mandible, many times in edentulous mandibles, you will see that the patients, the foramens are located more coronal because of the distal extension reduction of the ridge due to the bone remodeling over time. So, well, it's important to do a full thickness flap reflection all throughout the ridge, and don't be afraid to locate the foramen, to observe where the foramen is located, so that way you could have a visual landmark on where to go and where not to go. What that means for you is extending your flap to the level of the foramen is not going to damage the nerve. It is going to give you the ability to look at the foramen, but without damaging the nerve.
And once you identify and reflected both of those mental foramens, you could do some markings, either with a pencil, that's a surgical pencil, or a marking with your burr to locate exactly where they are. In your CT scan, you have measured already how far that loop goes in there. So if you have to go 5 millimeters mesial, you'll put your next pin 5 millimeter mesial. So you avoid that loop from that foramen.
What do we mean with loop? Loop means that the mental nerve, as soon as it exits the mental foramen, there is a portion of that nerve that continues on in the internal part of the bone, and it forms a canal anterior in the mesial aspect of the foramen. And that loop could typically go into 3 to 5 millimeters, but it could extend up to 10 millimeters. So that will make sure that we get to try to visualize that in the CT scan or radiographic examination. But it's safe to say that if you drill 5 millimeters mesial to that mental foramen, you will be in the safer zone.
And here comes the question, how many implants do I place? Do I place 2, 3, or 4 implants? Of course, 2 implants is going to improve the quality of life of your patients. 3 implants is going to be much better because it's going to create a tripod effect. And in yellow, you can see the mental foramens, and in gray, you can see the placement of the implants. We're going to be placing those implants anterior to the mental foramen. However, if we're able to place 2 implants anterior to the mental foramens, and if we have enough height on the posterior mandible, place 2 more implants at the position of the second premolars, then you're really going to have a very, very stable prosthesis, and patients are going to be very, very happy. Now, 2 implants is a huge upgrade for those patients. Imagine chewing only at 10% of your capabilities and now bumping to 50 to 60%.
These are very important aspects to consider when we're looking in the mandibular overdentures like this. If we only place 2 implants in the anterior segment as categorized today as a standard of care, that denture may have a high chance of being a rocking denture between the anterior to posterior segment of that retromolar path area. What is the key for success? The key for success is to be able to place those implants in the anterior zone, 2 or 3 in this case, below the retromolar area. What that means for you is that you have to do bone reduction enough that the anterior segment of your ridge is at the level or beneath the retromolar path. So what that means is that you have to be very aggressive in the alveolectomy, so that way you can reduce that ridge and avoid the rocking action of that denture. 3 will be better than 2, and 4 will be better than 3, of course.
Also think about the spacing in between your implants and your AP spread, which would be the distribution of those implants from the anterior to the posterior, which also comes into play based on the shape of that mandible. So you can transfer now the information that you had after those implants have healed, or you could take an impression the day of the surgery and transfer into a model. So you can do a lab pickup, or you can do a pickup in the mouth. And remember, even those overdentures are still going to end up in a glass of water at night.
So what that means for us is that we could transition our patients and sometimes offer the patients, for the limited financial resources that they may have or anatomical considerations, from a full removable denture to an implant-supported overdenture. And we could even go any farther and go from the removable to a fixed prosthesis. And a fixed prosthesis is going to help you because the patient is going to increase from the 60% that we have with the implant retained overdenture to a 90% chewing capabilities. What is the problem with going fixed? The problem is finances. And for that, a multi-fix system, or otherwise known in the market as an all-on-4 and so on and so forth, multi-fix system is going to help you to look at those atrophic ridges. In this particular case, and just make a pause in here, we could go rather quickly in this segment, because just a couple of you are going to be doing this procedure, so I'm not going to spend too much time, but you eventually will get there. And we have a manual that has been created on this case, step-by-step, that we'll be able to facilitate through you through MIS.
And in Guadalajara, as I mentioned, we're going to separate you depending on the procedures that you've elected, so we can go more in depth into every single procedure. So when you get out of there, you end up being experts of that procedure and feel very, very comfortable doing it in your practices.
Let's recap this case. In this case, the patient has an advanced periodontal disease, an advanced bone loss, and the problem with this patient is also protruded. And if you remember the picture before, had a very high smile line. What this procedure will call is going to be for removal of the teeth and placing implants, and to do immediate loading. As you could see in this radiograph, we could see that there is a lot of bone destruction all throughout the patient's mouth. The anterior ridge has mobility class 2. There's a lot of bone loss and very aggressive periodontal disease.
And even if you wanted to place implants on the posterior mandible on the right side, it would be pretty much impossible. So you need to rely on angled implants and placement of implants in between the mental foramens in order to have a successful outcome.
So in this particular case, once we did the procedure itself will call as the picture on the right side. So we perform alveolectomy, we perform a good distribution of our implants, and this distribution of our implants will call, in this case, for 4 implants in the mandible and 5 implants in the maxilla.
And this will allow the patient to have a first molar occlusion. So even though those implants are placed in between the mental foramens, you're going to be able to extend the occlusion of your patient all the way to a first molar occlusion.
Now, we will review the implant distribution in a moment, and that is very important for you to understand how do we distribute, where do we put those implants. And for anything else, the implant distribution will be a key for success. However, the important part of it is also look at the healing time. And what do we do during the healing process? So there will be, after we complete this procedure, a healing time between 4 to 6 months before we go into the final restoration. And there will be different appointments that we have to do. This is all written in the manual that we'll be happy to share with you so that you can consult that manual step by step.
Now, in order to have a successful treatment, it all starts with your treatment planning on how are you going to place those implants, how you analyze the case, and how you think about how the restoration is going to be. So depending on how much bone you have available, it's going to be the distribution of the implants, and it's going to be your determination to decide whether you need to angle those implants or not. Also, your anatomy is going to be playing a very important role into that decision making. So if you have bone to your first premolar, to your second premolar, to your first molar, or even if you have only bone available between your canines, remember that that's how Brånemark started all his initial studies with implants in the mouth, placing 4 implants in between the foramen to replace full dentitions on the mandible. Now, if you have full bone of volume on the top, it's very similar as on the bottom. And then when you start losing bone because of the pneumatization of that sinus, then you start to angle those implants or start moving them more anterior into a second premolar or a first premolar position. Or many times, you have to go and do other procedures like zygoma implants, sinus lifts, so on and so forth. So don't stay stuck to the all-on-4 word, because all-on-4 is just a technique where you can angle implants. We've learned throughout the years that angling implants is not going to be detrimental for those implants. There's parts and pieces to correct the angulations, and also being able to load those implants the same day that the teeth are taken out, that the bone grafting is done, that the implants are placed. It's going to play a huge psychological impact on your patients. Now, always think outside of the box. Just remember that all-on-4 is just a concept. You may need to do other procedures, like in this case where we had some impacted teeth, an impacted canine and a supernumerary tooth, and after the extractions done by a neurosurgeon, there was a lot of destruction. We had teeth that had to be removed, and we had to angle the anterior implants, not the posterior implants. So always keep in mind that as long as you stay within the range where your prosthetic components will allow you to correct those angulations, you're going to be able to correct and to be able to restore those patients very, very comfortable. Or think like an orthodontist. If you have cantilevers that are very long because you have to place those implants way in the front, if you eliminate one of those teeth and now you're placing your implant not on a premolar position but on a molar position, or instead of putting it on a first premolar position, you're doing it on a second premolar position, your cantilevers get shortened and the success of your restoration is even greater. Always keep in mind the AP spread is going to be very, very important.
And the AP spread refers to the space where the most anterior implant is placed and the most posterior implant is placed. That will determine the amount of cantilever that you go posterior. That means if you have a 1-to-1 ratio of that spread, that's how much you can cantilever posteriorly. Now, more implants doesn't mean that it's better. What is better is actually a better distribution of those implants to be able to account for that AP spread. So let's review very rapidly the restorative steps. Once we have this patient into a hybrid prosthesis, which is fixed and is loaded at the same time of the surgery, then we are going to go into the 4 to 6 month period of time, and then we're going to go into the restorative case. And the restorative goes as follows. It's going to be a custom tray impression if needed, not always is needed. You can use a stock tray. Then you go to a final impression. You go after that at next appointment to a similar as you would do for a fabrication of a full denture, which is wax rims, face bow, and bite registration. Then you're going to go into wax try-in with the jig verification and bite registration. And it's going to be a trying of the framework and the delivery of that prosthesis. So in the step 1 in this particular case, we created a custom tray to do the fixture level impression with an open tray on top of the SRA abutments or multi-unit abutments. In here, we use the impression coffins, open tray,
which are specific for those multi-unit abutments.
And then we do the impression for the maxilla, impression for the mandibles. You could see in here with the traditional approach of light body and medium body. The step 2, we'll send that to the lab. The lab will go ahead and give you back a verification of the cast and a jig. And this jig verification will result into make sure that that jig has a passive fit in each of the implants. So a radiograph has to be done to make sure that that jig is passively fitted. If it's not, then you have to section the jig and cure it in the patient's mouth, so that way you ensure a passive fit.
And this is one of the most important steps in the restoration of a full arch, because if those cylinders are not sitting very passively and you send this back to the lab and they fabricate a bar, that bar is not going to fit passively, and then you're going to run into a lot of problems, and you're going to have to send for the fabrication of a new bar, which becomes very, very costly.
So then the next the step 3 is going to be to, once your models are verified, you have to get the wax rims try-in. And then, as you would do in a regular denture, you do the face bow by registration, indicate your midline, canine position, and first molar position, so that way they can mount the teeth. You are going to also verify those records and make sure that you do not violate the original vertical dimension of occlusion. The next step, after a week of sending this to the lab is going to do a wax up try-in. So you're going to mount the teeth as a denture in a base plate supported only by 2 of the 4 or 5 implants that you have placed. And by doing this, you will be able to check and verify the patient satisfaction, occlusal records, all the movements as you see fit for occlusal movements. And from here on, you're going to go into sending this to the lab. What the lab is going to do is going to scan this. The scanning is going to do transfer this into a digital format and fabricate from a digital format a titanium mill bar. And this titanium mill bar typically takes about 2 weeks of turnaround time. They're going to send you back another final wax up try-in with this titanium bar in place. You're going to try it in. If there's some modifications, you do those modifications, and you send it back for processing. Finally, the final step after the milling of this is going to be the final delivery. So it takes about 5 weeks total to get to this point. Now, from here on, you're going to do your occlusion to a balanced occlusion to make sure that you do not replicate a canine guidance. You typically leave them in a mutually protective occlusion, and make sure that you do this in a balanced way. So obviously, the adjustment of the bite is very important. From here on, you deliver that, and then you review the oral hygiene, which is going to help you into maintain this.
Now, let me say something very important. Every implant that you're going to place in Guadalajara, whether it's for full arch, single, either you're going to do all extractions and the patients are going to be edentulous, every single patient is going to be restored, and every single patient is going to get into very strict oral hygiene protocol. Okay? We want to make sure that we go there to do a good thing for those patients as well. We're going to be learning. They're very kind to allow us to learn on them, and we're going to be giving back to them an opportunity that they probably never had of being able to have better teeth or be able to have teeth at all. And we're going to make sure that every patient that we see, that every implant that we place gets fully restored and gets into a protocol to provide better quality of better oral health and better quality of life to those patients.
And that's very important because there have been other courses where people have gone through, and it's uncertain whether those patients are follow-up or restored. We have very strict protocols, and we also continue with the research into the placement of those protocols of the long term. For this particular case, night guard is delivered, and the before and after is, you could see, is a big change for the patient.
And as we were mentioning, we put those patients in very strict protocol for maintenance. They come every 3 months for a 2-hour period where they really get looked into and make any modifications to try to preserve that quality of life that we're trying to give them by placing those implants for them.
Now again, don't forget that we'll be reviewing